everybody, and welcome to Commonwealth North. Thank you to today's registration volunteers, Carol Anderson and Paul Myrock, for helping us today. My name is Terry Smith, and I am the current president of Commonwealth North. This is my 12th year on the board. In my day job, I serve as the CFO for Airstrike and as president of Unified Operations, a finance and operations advisory firm. Our current fiscal discussions in Alaska demand the skills and experience you all bring to Commonwealth North. Our mission to educate Alaskans and provide them with nonpartisan research and analysis is unique. Thank you for participating in our work. Today we are pleased to welcome Charles Silver and David Hyman, the authors of Overcharged, Why Americans Pay Too Much for Healthcare. In their book, they outline why healthcare costs are so high and argue that in order to make healthcare better and less expensive, we need to change the way we pay for medical services. Instead of routing dollars through insurers, employers, public payers like Medicare and Medicaid, and politicians, consumers must control the money. They believe that healthcare will get better and cheaper as consumers exert pressure from below. Commonwealth North looked for years and has been searching for ideas to help improve healthcare for Alaskans while at the same time slowing the rapid rise in costs. In 2005, we issued a report that identified rising healthcare costs as unsustainable. That reforms were inevitable and that if unchecked, ever-rising costs could increase prices for Alaskan businesses and drive us out of the market. During President Obama's administration, our healthcare study group worked to understand the impact to Alaskans of the Affordable Care Act and to make specific policy recommendations to address the healthcare cost explosion. One of the group's key recommendations was to increase transparency in the business of healthcare. Greater cost transparency would give patients more information about anticipated financial obligations and allow for price comparison prior to the delivery of healthcare services. In other words, greater cost transparency would enable consumers to make more informed economic decisions. I am sure our authors will have something to say about this as well. National and local debates over how to reform healthcare continue. In Juneau, the legislature and governor will soon be making significant decisions about the state's healthcare costs and the services it provides. Our goal today is to encourage discussions that will identify policies Alaskans can implement that can finally have a meaningful impact. We know this is a complex problem. If reforms are indeed inevitable, Alaskans should be as well informed and engaged as possible so we have the ability to choose the best path forward. I'd like to briefly introduce our head table. I'll say more about our guest backgrounds in a moment. Mr. Charles Silver, to my right, adjunct scholar at the Cato Institute and professor of law at the University of Texas, and Mr. David Hyman, adjunct scholar at the Cato Institute and a professor of law at Georgetown University. Please help me welcome our head table. Would the members of Commonwealth North please stand? I'd like to personally thank you for your membership, your participation, and work to help educate Alaskans, including our policy leaders on Alaskan public policy challenges. I'd also like to invite the rest of you who were not standing to join Commonwealth North. We need your participation and your financial support. All right, everybody, you have question cards on the table. If you have questions for our speakers, please complete the question cards and hold them up, and one of our staff will collect them as throughout the discussion today. And now to our speakers. Charles Silver is an adjunct scholar at the Cato Institute and holds the Roy W. and Eugenia C. McDonald Endowed Chair in Civil Procedure at the University of Texas School of Law, where he teaches about civil litigation, healthcare policy, legal ethics, and insurance. His writings on class actions and other aggregate proceedings, litigation finance, medical malpractice, and legal and medical ethics have appeared in leading peer-reviewed journals and law reviews. In 2009, the American Bar Association awarded him the Robert B. McKay Law Professor Award for Outstanding Scholarship on Tort and Insurance Law. Mr. David Hyman is both a doctor of medicine and an attorney. He is also an adjunct professor at the Cato Institute and a professor at the Georgetown University Law Center. He focuses his research and writing on the regulation and financing of healthcare and on empirical law in economics. He teaches or has taught on healthcare regulation, civil procedure, insurance, medical malpractice, law and economics, professional responsibility, consumer protection, and tax policy. While serving as special counsel for the Federal Trade Commission, Professor Hyman was principal author and project leader for the first joint report ever issued by the Federal Trade Commission and Department of Justice titled Improving Healthcare, a Dose of Competition. Gentlemen, thank you for being here today. I'll hand the program over to you.
So thank you very much, Terry, for that gracious introduction. We're going to sort of bounce back and forth because you'll get bored watching us sit up here and talk to you. And we thought to make it a little bit more interesting, we'd start with a very short video that was made by the Cato Institute when this book was released last year. So let's see if it works. And it's going to be a very short video.
Saline, a plastic bag, water, and salt. A bag costs less than 50 cents to manufacture. Hospitals buy them for around $2 each. Why did Medicaid pay $928 per bag? It gets worse. That $24 pill has about 5 cents worth of medicine inside. That $18 diabetes test strip costs 56 cents. Some hospitals even charge new mothers $39 to hold their own newborn children. Why is our healthcare system so dysfunctional? Find out in the new book, Overcharged, Why Americans Pay Too Much for Healthcare. Visit cato.org/overcharged.
So we're going to talk about this book today, and we're going to, given the amount of time we have, touch on just a couple of the subjects that are covered. And the book's available for purchase either through Amazon, and we have some copies here if you're interested in buying it. We don't make any money off of it. The Cato Institute is very good at contract negotiation, apparently. In any event, we're going to talk about today is, I think, exemplified by some of these relatively recent newspaper clippings that I pulled together before this talk. So this is from the middle of last year. This is a couple from South Korea that was visiting San Francisco, so they were very much out of network. Their child, 18-month-old child, fell off the bed, wouldn't stop crying, so they took him to a local children's hospital, in fact, the premier academic children's hospital. And as you can see, they treated the child with a nap and a bottle of formula and then sent a bill for $18,000 for that obviously very technologically complicated set of services. And you might be inclined to dismiss that, and in fact the hospital wrote down the bill after there was some publicity about it. But what you see is that over and over again people get these exorbitant bills. So let me show you some other examples. This is a public school teacher in Austin. Public school teachers have very good health insurance, certainly compared to much of the rest of the population. He had the misfortune of suffering a heart attack, was taken by ambulance to a local emergency department where he received life-saving treatment. But he also got a bill for a total of about $165,000. His insurance company paid about $50,000, leaving him with a balance bill because he was out of network for $110,000. Completely unrealistic to expect him to pay it. Had he been in network, the bill that he would have received would have been dramatically lower and his financial exposure would have been lower. So this is another example of these sort of out-of-network bills. This is one of your fellow Alaskan citizens who needed surgery and ultimately decided to fly south in order to receive it. Medical tourism, which we talk about in the book, is one of the strategies that people have developed to deal with providers who have more or less a monopoly position and can set very high prices. Market exit through tourism like this is a way of dramatically lowering your costs. This is a very recent article from Salt Lake. The state of Utah is a pretty conservative place, right? But they're confronting the same problems that other states are with very high prescription drug costs. And what they decided to do was, if you're a state employee and you're taking one of about a dozen very expensive drugs, you can either have that drug filled in Salt Lake as you normally would, and the state will foot the bill, or they'll fly you to San Diego, put you on a bus, drive you across the border, You'll buy your drugs in Mexico, fly back to Utah, and they'll pay you $500 for your trouble. And they're basically leaving it up to individual state employees to decide whether they're willing to travel in order to avoid these very expensive costs. You also see this in the private sector. Walmart, a large employer, to say the least, confronting very high costs. They're trying to deal with high variation in the quality of care that's actually being delivered and high costs. And so as part of that effort, they decided to implement a second opinion program for some of their employees who received recommendations that they needed very expensive treatments. They fly those employees to premier academic institutions where they get a second opinion. This is a case study that was published in the Harvard Business Review, where the patient had neck pain and some tremors. Their local surgeon told them, you need surgery, and Walmart paid to fly them to Geisinger Medical Center in Pennsylvania, where they diagnosed the patient with Parkinson's disease, not with a surgically alleviable condition. So the positive here was obviously Walmart avoided having to pay for a very expensive surgery, but the more important issue that I think you should focus on is the patient avoided an unnecessary surgery that wouldn't have treated their problem. And obviously these are individual anecdotes, but nonetheless they're indicative of the media environment in which people understand the performance of our healthcare system, as well as the way in which we pay for healthcare. So let me now switch to pharmaceuticals and turn it over to Charlie, my co-author.
This is Martin Shkreli. How many of you have heard of Martin Shkreli? Everybody has heard of Martin Shkreli. Why? Because he was briefly the most hated man in America and the poster child for pharma greed. None of this fazed Shkreli. He enjoyed trolling his critics. Once he boasted of having a charity auction for the right to punch him in the face. And he claimed to have gotten a bid of $78,000 for the privilege. And seeing him smirk up there, you can kind of imagine why someone would want to slap him silly. His offense was that he raised the price of a drug called Daraprim after taking over its manufacturer, Torin Pharmaceuticals, from $13.50 a pill to $750 a pill. Daraprim is a drug that treats a disease called toxoplasmosis, which is a parasitic infection that affects people with weakened immune systems for some reason, possibly because people with HIV are often in this situation. The press focused its spotlight on Shkreli, and other pharma companies decided that their strategy would be to distance themselves from Shkreli by claiming that he was a bad apple in an otherwise good industry. And Shkreli answered back by saying, hey, I'm just doing the same thing that all of the pharma companies do, which is to gain a stranglehold on the supply. His company was the only supplier of Daraprim, even though it was off patent. It was a sole supplier drug. It was also the gold standard treatment for toxoplasmosis. He said, I'm the sole supplier. Whenever you're a sole supplier, you charge more. All the pharma companies did that, and he was right. If you look at the history of drug pricing in recent years, what you find is that price increases for both generic drugs and brand name drugs are exceedingly common, and that pharma companies all play basically the same game, which is to use something, which it might be a patent or it might be something else, to become the sole supplier of a drug, and then to raise the price as high as possible. And here are some examples. Colchicine is a treatment for gout. It went from 9 cents a pill to $4.85. There are a bunch of others. These are all old drugs that were around for a long time. Branded drugs present just way too many examples to mention. For example, Harvoni is a treatment for hepatitis C, thank you. And it went on the market at something like $90,000 for a course of treatment. Insulin is a really interesting example at the bottom here. Insulin is a very old drug. It's been around for a long time. There are 3 makers of it. And today we've reached the point where many, many people cannot afford the insulin that they need to treat their diabetes. It's just too expensive. And so we're having a nationwide health crisis because the 3 manufacturers of the drug have engaged in lockstep price increasing. They've played a game which we describe as tit for tat, or you might think of it as follow the leader. When one of the companies raises the price, instead of lowering the price and trying to suck away that company's market share, the other companies follow it up the ladder. And as long as they all keep playing this game where they raise the prices in lockstep, they can make a fortune, right? Because there is no competition. When the companies are discovered playing these games, they often come up with inventive excuses. The excuse you usually hear is that they have to raise the prices in order to pay for the cost of developing new drugs to cover their R&D. There are lots of studies that indicate that there's very little connection between the price increases and R&D. In Shkreli's case, he didn't invest anything in R&D. He said his view was his stockholders expected him to make a profit, therefore he had to sell Daraprim at the highest price he could. Of course, he was the main shareholder in Torii, so when he said his shareholders expected to make a profit, he was really saying he expected to make a profit. His conduct was so outrageous that the Loan Institute created the annual Shkreli Awards, and the winner last year was the CEO of Nostrum Pharmaceuticals, which raised the price of an antibiotic by 400%, from $475 a bottle to almost $2,400 a bottle. When asked why, the CEO, Nirmal Mulye, said, "I think it is a moral requirement to make money when you can." And so now we have simplified morality into doing what is in your self-interest. Makes it a lot easier to think about. David? Oh, this is a slide, I'm not going to read it to you, but this is a slide, the purpose of which is to give you a sense of the range of subjects that our book covers. It really covers the waterfront of healthcare. You can look for your favorite form of healthcare delivery, and I can pretty much guarantee you that there's a discussion of it in the book, and that there are examples in the book showing how things have gone wrong in that sector. So we have problems with open-ended reimbursement for patented pharmaceuticals. You have to ask, why can drug companies just raise the prices with impunity? It's because there really are no limits on what they can charge, unlike in normal markets where people's willingness to pay imposes a natural ceiling on what sellers can charge. In the pharmaceutical sector, their money comes from insurance companies and government payers, and those are not in the business of setting limits. They're in the business of paying bills, and so they take advantage of that. There are also tons of games that providers play, such as upcoding, in order to raise revenues. And then we have the problem of surprise medical bills, which was the #1 concern among voters in 2016. So we cover all of these things, and if you read the book, you'll see.
So the discussion so far, and what we're going to talk about going forward, it's important to emphasize, involves bad apples, right? And sometimes the entire bushel is rotten. Admittedly, maybe this is not a good Alaska metaphor, because I don't think you have apple orchards here, right? When I present in Wisconsin, people get this right away. But nonetheless, we're going to focus on lots of bad behavior. It's important to acknowledge and recognize that there's good behavior and lots of conscientious, hardworking people in this field as well. Often we subject them to incentives that encourage them to do the wrong thing, not to serve the best interests of their patients or to deliver care in the most sort of low cost and quality effectiveness standard. But the point, you should not take away from this that we're condemning everybody and everything, right? We, at the end especially, will highlight examples where things are working better and things that we think we ought to do more of, right? So it's not all doom and gloom, although you've got to get through some of the doom and gloom to hear the good news. So more doom and gloom is, well, how much fraud, waste, and abuse is there actually in the system? And there have been a series of studies and estimates of this over time. The sort of most careful series of studies, which have their own set of weaknesses, were done by the Department of Health and Human Service, Office of the Inspector General. They do desk audits of the submitted bills to try and see whether they should have been paid, right? So they don't go and actually see whether the patient needed the treatment. They just ask whether the paperwork is in order. And it can be out of order for all sorts of reasons. They filled out the wrong codes, the patient is too young to receive the treatment, so this is primarily Medicare bills that they're using, things like that. The numbers are wrong as to the physician that was providing it. In any event, they pretty consistently find on the order of 8% of submitted bills shouldn't have been paid. Now, this is a shockingly high error rate, right? If you think about the post office delivering 8% of the mail incorrectly, or 8% of the planes landing in Anchorage landing in an unsafe manner, we wouldn't tolerate that level of misconduct. But in the healthcare system, the system is set up to pay these bills quickly and efficiently and at a very low cost, and not to spend a lot of time investigating. We have structured our bill payment system, particularly in the public sector side, as a passive recipient and payer of bills, not an active manager. The standard estimate for fraud and abuse in the healthcare system is 10%. That's a little different category than improper payments, but it excludes waste. Waste are treatments that are provided to people that don't actually need them, unnecessary treatments, treatments that have been proven not to work, but somebody is still doing it, drugs that are dispensed but not actually used, thrown in the trash and billed. And so the estimates there, the IOM is the Institute of Medicine, which is one of the national academies. They came up with a figure of about 30% using 2009 data. Berwick and Hackbarth. Berwick used to run the Medicare program. In an article in 2012 using 2011 data had a slightly higher figure. So these are, if you thought 10% was bad and you add in waste to the total, we're talking about a very large sector of the economy that appears not to be operating particularly efficiently, to say the least. And so I thought I would put a sort of human face on some of the waste with a couple of examples. This is Dr. Jacques Roy, who's a primary care doctor in Texas. Go Texas. But he took the federal government for $375 million. And you should ask, well, how did he do that? Well, because he had a pen or an electronic keyboard, and what he did was he executed prescriptions authorizing home health care for patients, and then home health care agencies use those forms to bill the federal government for those services, even though for a lot of the patients they didn't actually need the services. Some of the patients never even received the services. The average physician executes a couple of these a month. Dr. Roy did 5,000 in a single year. He was a home health authorization executing machine. It's hard to believe he had any time to practice medicine, given all the time that he had to have been signing his name. And if you had done a sort of simple frequency distribution of how many of these were executed by physicians, he would have stuck out like a sore thumb. But nobody was really paying attention. They were just processing the bills as they came in. He gets suspended in 2011, but he still keeps doing it. And they keep paying the bills. He finally is convicted in 2016. The good news is, once he was incarcerated, he stopped submitting home health care bills, right? This distinguishes him from some other health care providers who were incarcerated and continued executing them, and guess what? The Medicare program kept paying it as well, because the part of the program that was going after the bad actors was not communicating with the part of the program that was saying, here's how we should pay the bills that we receive. So that's $375 million. Let me talk about a slightly less grandiose fraud, but one that involved a much higher risk of patient harm. And so the backdrop for this is to talk a little bit about pharmaceutical pricing. So wet macular degeneration is a disease that affects the elderly. It can cause blindness. The good news is ophthalmologists developed a very effective treatment. It involved injecting small amounts of a drug directly into the eye to basically stop the disease in its tracks. The good news is ophthalmologists are good at injecting things in your eyes. And they developed this treatment on a drug that was originally deployed for the treatment of colon cancer, called Avastin. And it was really cheap when you used it in the minute quantities that you needed to inject in people's eyes. Only $60 a dose. The drug company that was responsible for Avastin felt like they were missing out on a major financial opportunity, so they developed a different drug, effectively identical, for the treatment of wet macular degeneration, and they priced it at $2,300 a dose. Now, if people were spending their own money, they'd obviously prefer the $60 a dose drug to the $2,300 a dose drug. And in part, they were spending their own money because the drug carried a 20% copayment. If your doctor used the cheap drug, your 20% of $60 doesn't cost you very much. 20% of $2,300 costs a lot. The good news is most doctors continue to use the less expensive drug. But some doctors use the more expensive drug, and you should ask yourself, well, why would they do that? Well, part of the answer, certainly not all, is the way the Medicare program paid physicians for dispensing both of these drugs was 6% of the drug cost. They've actually dropped it now to 4.3%, but at the time that I'm talking about, it was 6%. So 6% of $60, not very much. 6% of $2,300, a much more sizable increase. Now, admittedly, this drug had been packaged exclusively for ophthalmologic treatment, but otherwise it was effectively the identical drug, had the exact same consequence. Good news, most doctors resisted the financial temptation that the Medicare program had created. Now I'm going to talk to you about somebody who didn't. This is Dr. Melvin. He was an ophthalmologist in South Florida. He used Lucentis, the more expensive drug, like it was going out of style. He, in fact, billed the Medicare program a total of about $135 million, most of which, but not all of which, went back to the pharmaceutical company to pay for the more expensive drug. He had a habit of diagnosing every single person who walked into his office with wet macular degeneration. Not good medicine. He also quadruple billed for the drug because of the large size in which it came, and he made a very large amount of money off of it. When the federal government finally caught up to him and started investigating, he used some of the money that he had received to make very large campaign contributions to a senator from New Jersey, a long way from Florida. And the senator and his staff then went to bat for Dr. Melvin against the bureaucrats who were trying to close down this particular racket. And this quote here, can everybody read the quote? Yeah? So the quote, "Bad medicine is not illegal. Medicare should pay these claims." The chief of staff for Senator Menendez called up, one federal employee called up another federal employee, the federal employee that was responsible for not wanting to pay these bills, and told them, just because it's bad medicine doesn't mean you shouldn't pay it. No one would behave that way with their own money. It's understandable, given these sort of political dynamics, why someone might feel free to make this argument if they didn't expect it to end up in the newspapers, or as it happened, testimony at trial when Dr. Melvin was ultimately prosecuted for fraud and convicted. So a sort of short example that shows the way in which bad incentives and people who, shall we say, are not as good at obeying the rules can exploit a system that's set up with the best of intentions to provide treatment to the vulnerable among us. And now let me switch to the broader issue of surprise medical bills and turn it back to Charles.
One footnote to the discussion of Lucentis and Avastin, although David emphasized that a lot of optometrists and ophthalmologists, to their credit, used the cheaper drug, the number who used the more expensive drug added $1 billion to the cost of Medicare in 1 year. So this is a major amount of money, right? It's a large amount of money that's being sucked out of the government's treasury because of bad incentives that Medicare creates. On the subject of medical bills, I mentioned before that healthcare was the #1 concern of voters in 2016. According to this survey, the issue that voters were concerned about most was not prescription drugs or their health insurance premiums. It was unexpected medical bills. These are bills that come out of the blue after you have a surgery or some other procedure from a provider who you might have thought was in network, but turns out not to be in network. And it's, oh, we have a video. Oh, we're going to show you a video, so I don't have to explain these things. Go ahead.
My name is Paul Davis. I'm a retired family physician. A couple of years ago, my daughter, Liz, was experiencing some severe back pain. And so she consulted a physician. He determined that she would be eligible to have an operation to fix her back, and she underwent the procedure successfully. When she was discharged home, she was given a prescription for a pain pill. She had insurance, and it paid for almost all of the operation except for a deductible. Then the physician ordered a urine drug screen. She never was given the results of that test, and so she basically forgot about it. About a year after the operation, she got a call on her cell phone and was told that she owed $17,850 for this urine test. When I found out, my immediate reaction was, this is fraud. This is price gouging of incredible magnitude. I was the program director for the physician assistant training program here at the local university. For $45, we did background checks and urine drug screens on our accepted students. There is absolutely no way that what they did was worth the amount of money that they charged my daughter. They tested for things like Valium or Xanax, $2,975. Methadone, which was $850. One of the most amazing things on here to me is they did skeletal muscle relaxants, $1,200. All of these things just outrageously overpriced and aren't even really necessary. Not a routine post-op practice. My biggest concern was my daughter and her husband and what something like that could do to their credit rating if they did not settle this bill somehow. And so I paid $5,000 to these people to settle this bill. The lab's attorney said that their pricing is consistent with the industry. And I was just livid that these people would have the nerve to charge this amount of money for this service. In Cato's book,
So, there's more of this, basically a promotion for the book. So we're here to do that. So you don't need to listen to that. But the question now is, well, where do we see balance going?
Yeah, there are a lot of questions, I think, but one relating to that video that I think is very interesting is that the patient, the daughter who provided the urine sample, didn't even ask how much the urine test would cost before she gave the sample. She just did what everybody does, which is, oh, my doctor recommended a test, I'll get it done. And this is the way we have come to think about healthcare in our third-party payer-dominated world. We don't even ask about the costs. And so then she gets hit with this astonishingly high bill, and it comes as a complete surprise. So where do these bills typically come from? The major offenders are not labs, although there is an article which you would enjoy reading called, what was it, there's gold in urine, or something like that, because urine testing is an enormously profitable business. But apparently the major sources are things like emergency departments. There are some hospitals that contract out the operation of their emergency rooms to independent companies that are good at managing them. And the doctors who work for those companies are not typically in the same networks as the hospitals where the emergency rooms are located. And so every patient who shows up at the hospital thinking, oh, I'm in network with this hospital, I'll be covered, is at risk of being hit with a balance bill for out-of-network charges. And there are literally, in my home state of Texas, hospitals where this is true, where something like 85% of the patients get hit with balanced medical bills. But it's not just emergency departments. These bills can really come from anywhere within the hospital. So many of you have probably had the experience of having a surgery, and after the surgery you get a separate bill for the anesthesiology treatment. And the anesthesiologist may not be in the same network as the hospital or as the surgeon who performed the surgery. So why does that persist? Because the anesthesiologist doesn't have to be in the network in order to treat you. They're people who are brought in because the surgeries can't proceed without them, and they have guaranteed patient flows. So they just go ahead and bill whatever they want, and then people wind up being on the hook for the balance. One of the interesting things about balance billing is that we don't see it anywhere, to our knowledge, except in the healthcare sector. So the way we offer you as a metaphor to think about this is an automobile body shop. So an automobile body shop is a repair shop for your car, and a hospital is a repair shop for your body. If you take your car after being involved in an accident to an automobile body shop, they'll fix the car, and you'll get one bill for it. And they'll probably tell you in advance what it's going to cost, and your share of the bill will probably be your deductible. And then that's the end of it. Can you imagine yourself 6 months after you took your car in for repairs, getting a balance bill from the guy who painted your fender? You can't imagine that, can you, right? I mean, if you got a bill 6 months after having your car repaired for another $1,000 from the guy who painted the fender, you'd go nuts, right? You'd say, this is crazy, I'm not gonna pay this, and you'd call up your insurance company and tell them, you need to, tell this guy what's going on, right? And then you tell your friends, don't go to this place because their billing practices are terrible. You probably post comments online about how awful they are. And pretty soon the automobile body shop would learn that they can't do this because they're going to lose business if they do this. And so they'll start packaging their bills in ways that are reasonable, which is in fact what all of them already do. So how can hospitals, which are just body shops for your body, get away with this practice? Our view is that they can do it because they don't face the kind of competition that automobile body shops do. People have limited choices when it comes to hospitals, and hospitals face relatively little loss of business as a result of sending out these balance bills. And as in the example involving the urine test, the patients actually pay many of these balance bills. So they bring in money. It's not for their own funsies that hospitals or providers send out these balance bills. They collect on them, and the studies show that the larger the balance bill, the more money they collect. So they're making money on these things. They're not facing a loss of business by sending them, and so the practice persists.
So I should tell you there's a recent study that finds one area where there's some pushback for balance billing, and it's moms who go into a hospital to give birth. If they get a balance bill, a surprise medical bill, there's an appreciable drop in their willingness to go back to the same hospital. But that's very different than the way most people make decisions about when and where they receive care, right? Labor and delivery is a sort of known event. It's planned for. Going to the emergency department, you don't sort of negotiate with the ambulance as to where they're going to take you. And so the competitive forces that would otherwise work with auto body shops are dramatically muted when it comes to lots of other areas of the healthcare system.
So why is our healthcare system so dysfunctional? Why is competition impeded? Our view is one main reason is we rely excessively on third-party payments. So what do I mean? I mean Medicare, Medicaid, TRICARE, and insurance companies. Anybody who's other than the patient who is responsible for the patient's bill. The average patient at the point of delivery pays about 11 cents on the dollar for healthcare. So 11 cents comes from the patient and 89 cents comes from some third-party entity. So who's the real customer? The real customer is the third-party entity. And what the providers are trying to do is to maximize their flow of money from the third-party payers. Well, the one consequence of this is that the patients don't shop. I mean, for example, everybody in this room, I bet, has gone to a doctor. And you showed up and you say, where's your insurance card? Hand them your insurance card and find your copay is $30, right? Everybody's had that experience. Well, why would you shop among doctors on the basis of price if everywhere you go, you're gonna pay $30 because that's your insurance arrangement? There's no incentive at all to shop on the basis of price because really you're spending mostly somebody else's money. And so when we use insurance to pay for things, we dull the incentive to shop. And one of the big problems in healthcare is that we use insurance to pay for everything. We talk about doctor's office visits. A typical doctor's office visit might cost a total of about $100. How many of you use insurance to pay for anything else that costs about $100? I bet you can't think of anything outside the healthcare system that you would use for insurance for. And that's not the way insurance typically works. If you have homeowners insurance, for example, it doesn't pay you to upgrade your kitchen or to replace your carpeting or to get a new coat of paint on the house. It pays if there's a catastrophe, right? If your house gets flooded or your house gets struck by lightning and catches on fire. It's there to prevent or to protect you from the financial consequences of a catastrophic loss. The smaller costs you have to pay for it yourself. It's the same way in all lines of insurance, right? Life insurance doesn't pay you if you get sick and miss a couple of days of work. It pays if you die, right? A big catastrophic event. But in healthcare, we use insurance comprehensively. And that's a problem. Why do we use it comprehensively? Well, for a lot of different reasons. One of them is we are encouraged by our tax laws to get as much insurance as we can. So many of us have insurance through our employers, and the dollars that we use to pay the premiums for insurance provided by our employers comes out of our pre-tax salary. That means that we save a lot of money by buying insurance through our employers. And it also means that we save more money by buying more insurance. So our incentive is to maximize the value of the tax incentive by expanding the range of things that insurers covers as broadly as we can. And so we have incentives to maximize our use of insurance. We also have insurance mandates. So we have things that states and the federal government require insurers to pay for, including things that people don't necessarily want to pay for, right, through their insurance. They may be services that they'll never need. And then we have problems on entry to markets, which we'll talk about more later, I expect. The last thing that we have is a very corrupt relationship between the healthcare sector and our governments. So the way things work is that we have the medical corruption of politics. So the government or these insurance companies are sending money into the healthcare sector. The healthcare sector wants the flow of money to continue and to increase. How do they ensure that it continues and increases? By taking some of the money that they receive and putting it back into the political process through the form of contributions and lobbying. And so we see this vicious cycle where the money keeps increasing, the pressure on politicians to increase the flow continues to rise, and eventually we're all bankrupted. That's the medical corruption of politics, but there's also the political corruption of medicine. Because as I said, when the physicians and hospitals and other providers are trying to please the payers, right, they're trying to maximize the flow of cash from the third-party payers, the interest of the patient becomes secondary, right? The delivery of services that don't work is a source of revenue. And so there is an incentive created by the system to corrupt the judgment of the providers. No longer do they care mainly about what's good for the patient, instead they have conflicts of interest that are built in. And the evidence is quite clear that these conflicts create an ocean of waste. I mean, we're not talking small potatoes here, as David pointed out. The estimates are that 1 out of every $3 spent on healthcare is wasted. Well, our healthcare sector is something like $3.5 trillion. 1 out of every $3 is more than $1 trillion a year in waste. That's just crazy, but our system perpetuates that.
So the book has a chapter that talks about what we view as blind alleys, and single payer or more government oversight we think is one of those blind alleys. Because we're running out of time and I want to get to some of the reforms, I thought we'd just very briefly sketch out why we have serious questions about whether more government regulation of the sort that's given us the things that we've just spent the last half hour or so talking about is probably not going to get us where we want. So when people talk about single payer, it's at least worth asking, well, which single payer do you mean? Because the federal government operates 3 very different programs, which are single payer for a pretty large beneficiary pool for each of those programs. So Medicare, Medicaid, and the Veterans Administration. So when someone says, I like single payer, you should at least ask them, well, which one of those do you mean? Or to add a little local color, the people who ran the Alaska Psychiatric Hospital. Do you want to turn our entire healthcare system over to them is at least a question that's worth asking. The other important thing to highlight about a single payer is it's going to require pretty dramatic increases in taxes and spending. The sort of conservative estimate of Senator Sanders' single payer proposal is that it's basically going to require $33 trillion in new spending over 10 years. So effectively, our entire healthcare budget currently on top of our current healthcare budget over 10 years. So that's a very large tax increase that will be required. And although the advocates are enthusiastic about it, the 3 states that have flirted with single payers strategies have all gagged. And these are deep blue states, all of them looked at single payer, and when they realized how large their taxes would have to go up, the voters just said forget it. And then it suddenly died. We have a discussion in the book that I think we should skip in the interest of time about why the typical measure that's used to argue that Medicare is more efficient is problematic. And I'll skip these slides in the interest of time, but I'm happy to talk about during the Q&A why we think this particular measure actually doesn't capture efficiency. And so then the last issue we want to flag about single payer is a typical argument is, so why does it work elsewhere? And the answers are complicated. I think different countries have differing versions of single payer. Some of them are actually much more market oriented. But what we say and highlight in the book is our government is much more susceptible to pressure from voters and from special interests than many other countries. And this is a slam on Washington, D.C., just so we're clear, not on the good, hardworking people in the Alaska state government. But our government often behaves as though it is run by idiots. And so would you really want to turn a seventh of the economy involving issues that are near and dear to everybody's hearts to some faraway government bureaucrats? So what should we do? The book the last part of the book highlights these issues, and they sort of follow directly from what we've said already. We think we should encourage market entry and competition. We view those as critical to making the system more responsible to patients rather than insurers and third-party payers. We think we're using insurance the wrong way, so we should use insurance for dealing with catastrophes, just like we do in other parts of the economy. But for lots of other things, we think self-pay is going to be very important. For branded pharmaceuticals, we actually agree, interestingly enough, with one of the proposals Senator Sanders makes, which is our current patent system is not going to get us to cheaper drugs. If we want cheaper drugs, we should pay for them directly on budget using a prize system, and then produce the drugs at cost. And for generic pharmaceuticals, we think antitrust and FDA reform are going to be critical. We should exploit federalism. If you here in Alaska want to do something different, we think you ought to be allowed to. And we're not going to tell you what it ought to be because you know your own state better than we do. But the same should apply to Massachusetts. We shouldn't, or any other state, we shouldn't try and do a top-down federal solution. We think we should fix the tax subsidies. If we're spending too much on health care, we shouldn't subsidize people to spend money on health care. But we should subsidize people who need it, but we should subsidize them not by giving them insurance. We should give them money in the form of, you can think of it as a restricted voucher or cash, depending upon which strategy you want to use, along with a catastrophic coverage plan, and let them make their own decisions. That'll put people in the driver's seat rather than third-party payers. And then the last slide, and I think we're out of time, is given what was said earlier about your organization and its enthusiasm for transparency, the question you should have is, well, where do we see transparent and reasonable pricing? And we have a list here of where you see it. And we encourage you to go to the Surgery Center of Oklahoma's website. They have a little stick figure with dots on it, and you click on one of the dots and they'll tell you how much they'll charge to do surgery of a particular type on that part of your body. Very different than your experience if you called your local hospital or asked your physician, what will it cost to have this done? They don't know, they can't tell you, but Surgery Center of Oklahoma does. Thank you very much for your attention, and we're happy to take your questions.
Well, it's phenomenal. Appreciate the information. We are definitely appreciative of all the ideas and the homework you've put into this. We have some questions, and Aaron, do we have some other cards that we can bring forward? I'm going to try and paraphrase where needed. So one of the first ones is
I feel like I should have John Carson's contact.
Sure. certain information sharing, right? And as lawyers, do you see any way around the HIPAA restrictions that are added barriers to the kinds of things you're talking about?
I repeal HIPAA. I mean, HIPAA, for those of you who don't know, is the Health Insurance Portability and Accountability Act. And it's a very long statute. There's a single paragraph in it about privacy. And the paragraph says, if we, Congress, can't figure out how to regulate privacy, you, the Department of Health and Human Services, should figure it out for us. And they wrote several hundred pages of regulations, which were left as a gift by the departing administration, the Clinton administration, on the front step of the incoming George W. Bush administration, which flirted with not just killing it entirely, but ultimately decided to allow most of it to go into effect. The Congress never actually debated this or thought it was a good idea. It's a bunch of people in a building in Washington that tried to envision every conceivable circumstance and wrote incredibly detailed and prescriptive rules. Without much in the way of evidence that there was any problem with the state-level approach to regulating privacy, which varied from state to state, as well as some private litigation which dealt with the gaps. And so I think there's very little evidence that HIPAA has had any of the promised benefits, but it's imposed huge costs. I just get rid of it.
Very good. As a follow-up to one of your examples, the $350 million bad actor, how long was the conviction and what was the return on investment?
Well, I'm a little concerned about the second question because it suggests someone's looking for a business opportunity. On that point, there's actually was an article that appeared in a major mass media publication that said how to commit Medicare fraud in 6 easy steps. And they gave literally step-by-step instructions on it and said, listen, anybody with a high school degree can do it.
You have to have a computer too.
You need a computer, yes. It's time-consuming to fill these forms out individually, but with a computer you can bulk submit many, many bills. Some of them will get rejected, but enough of them will get accepted that they will deposit large sums of money in your bank account, and then you close the bank account and move on and hit them again but under a different name. So pretty high return on investment. That was shared between the home health agencies and Dr. Roy. I don't recommend this, right? Incarceration is, a known risk. Unfortunately, not a high enough risk given the base rates of fraud. And what was the first question? I'm sorry.
I was just more curious about any idea of like the return, how much was received from?
Oh,
No.
Yeah.
so almost none is without knowing the details. The way that the government describes its approach to these cases is pay and chase. Okay, so they pay out the money, and then if after the fact, sometimes 3, 6 months, sometimes a year or two later, they discover that they shouldn't have paid it, they go try to find the people and the bank accounts, and they have had limited success in dealing with the sorts of people like Dr. Roy and the home health agencies. You just shutter the home health agencies. Major pharmaceutical companies, on the other hand, are solvent entities. You know where they are, you can find them. So it's the physicians that have been targeted that end up serving jail time, whereas the fraudsters often have just moved on.
Yeah, all the big recoveries are from pharma companies or hospital chains, I think. I don't think the sentence for Dr. Roy probably said he had to make restitution, but we'll never see it.
Not realistic. Good question about competitive bidding. Competitive bidding reinforces competition and drives costs lower. Why have we not employed this process on all products and services within the medical community?
Because when we tried, there's an incredible degree of pushback. I mean, they tried to do this in the durable medical equipment area for a long time, and the DME suppliers said, oh, it won't work, it's complicated, we don't want it, blah, blah, blah. They delayed it for, I think, a decade. David probably knows the history of that better than I do.
Yeah, so this is an example of the accessible/vulnerable to special interest pleading, right? So nobody wants to be the person that deprived someone's grandmother of an oxygen tank. And so the people that make durable and that distribute durable medical equipment have plausible sounding arguments as to why competitive bidding will undermine their ability to be there at an instant notice to deliver the new oxygen tank. But the net result has been, although we use competitive bidding for government procurement in pretty much everything else the government buys, we haven't done it in the healthcare sector, and attempts to do that, there's been pushback from not just DME providers, but there was a proposal to do something similar for Medicare Advantage. And the insurers said, well, wait a minute, that's not fair, unless you're going to do competitive bidding for Medicare Part A and B, which are the separate sort of freestanding parts of Medicare. And so the net result is we haven't made any progress on using competitive bidding, although it's an obvious strategy for driving costs lower.
Very good.
One last point, it's important in thinking about competitive bidding, right? It's easy to specify what the contract should look like for paper clips and paper. It's harder for fighter planes. It's really hard for healthcare.
Sure, sure. The question about the subsidies for the healthcare exchange, do you think those align with the goals and those that need the financial help?
So it's a complicated question because there are multiple subsidies, right? So there's, and some of them have phased out over time. I think the intuition that you should subsidize people that have less was sensible. Our argument is you should do that not to subsidize them to buy insurance, especially expensive insurance, so expensive and with such high deductibles that we actually see the exchange policies as moving closer to our people using their own money for most of their expenses, as opposed to just giving people money or a restricted voucher, right? So I think the intuition that you should subsidize people was sensible. Part of the complication, this is too tax nerdy even for me, but you're running two subsidy systems in parallel, right? You've got one subsidy system for people who get their coverage through employers, and a different subsidy system for people who get their coverage through exchanges. And it's important to actually send consistent incentives across those two subsidy programs, and it doesn't, not even close.
I don't think these are really subsidies for people as much as they are subsidies for insurance companies, because these people are not going to buy insurance without the subsidies, and when they get the subsidy, they're going to have to pass it through to the insurance company. In the same way, the Medicaid expansion is very much a subsidy for healthcare providers. So the people who participate in the expansion, they don't get the money. It doesn't go to them. It goes through them to the healthcare providers whose burden of delivering uncompensated care is greatly reduced.
Quick question. Going back 7 or 8 years ago, one of the largest triggers that increased costs in Alaska for the tours and tours healthcare system was some of these medically necessary, like stomach stapling and things of that nature, and some of the vans. And what they found is that those procedures caused unintended consequences. And the question really is those types of procedures and how you trade-off of driving behaviors and healthy lifestyles and how that.
There is no single answer to a question like that. I mean, that's why in a market, I can decide what kind of car, right? I can buy a very high-end car. I can buy a lower-end car, like the one I just bought for my stepson, is a bare bones model Impreza. You know, there are different things that suit different circumstances, and one of the things you have to ask is, well, how badly in need of the surgery is this person? And, what's their risk profile when it comes to assessing the likelihood of secondary side effects? And, how much can they afford to spend? I mean, there are just all kinds of questions that have to be answered in connection with an issue like that one. The government can't make them or shouldn't make them for everybody. Instead, people should be weighing these considerations themselves, the same way they do all kinds of other considerations that bear on their health and well-being. Often, one of the points that we really need to get across is that often there is much more bang for the buck to be had from things other than intensive medical treatment than there is from healthcare. So things like education, for example, have enormous health payoffs. Stable housing has an enormous health payoff. All these things, if you look on the internet under social determinants of health, you'll find a very large literature on things other than healthcare that contribute greatly to health, more so than intensive medical treatments does. The bang for the buck on those is actually quite limited. So we need to give people the choice of how they should spend their money. Maybe one person in this position should go to a gym and hire a personal trainer or something like that, whereas somebody else, because their knees are worn out, say, should go to the lap band surgery. There, again, is no one right thing. We got to let people figure out what works best for themselves.
Yeah, I would just add to that, a different way of thinking about this conceptually is our healthcare spending is volume times price, right? So the number of services that we're providing times the price per service. Now, things can get musty and complicated, but that's a useful starting point. So when people are completely insured, they don't really care about the price, and in assessing whether they need the treatment or not, volume, they basically ask, can I benefit from it, and what are the direct costs that I'll suffer, and everybody's hopeful and optimistic, and so sometimes at the margins they're willing to have things done that they wouldn't if they were bearing more than 11% of the cost at the point of service. And if you're worried or thinking about the problem of how do I lower healthcare spending, you should think separately about the volume effect versus the price effect. The evidence is very clear that when you compare us to other countries, the big differences are not in volume, they're in price per unit of service. But those differences come from our open-ended reimbursement system.
And in closing, just one question about how do you see behavioral health services integrating into the primary health care, and how does that create cost savings?
Behavioral health.
So yeah, as behavioral health and
Like wellness, or?
I think it's I
Mental
was thinking more mental health is kind of where I thought.
Mental
health.
No?
I think these are important drivers of healthcare spending, right? And I think we don't have a great, we as in us as a society, not just us individually, although it's us individually as well, don't have a magic solution to that problem. I think attempting to write regulations that will mandate a particular approach are not going to work very well because of the diversity of circumstances that people are in. I think you should take account of that when you're thinking about how to subsidize people and how much to subsidize people. But you shouldn't assume you know what the answers are as across society, let alone across an individual state, let alone for Anchorage versus, say, Juneau.
You know, we face, in this area of mental health, we face very difficult choices. But the starting point for analysis should be, in my opinion, that unless a person has been adjudicated incompetent, they are responsible adults who make their own decisions. And so these people who receive mental health treatments, for example, they sign leases for apartments, they buy cars, they enter into other kinds of contracts, right? We treat them like responsible adults, except if they've been adjudicated incompetent, and then they have a guardian or a trustee or somebody like that appointed for them. Obviously, this process of dividing people, of sorting them, does not work well. But that is an ineradicable problem, it seems to me, and that should not drive the rest of the system. Instead, it should focus us on the people who really can't take care of themselves. Target our efforts at them.
Very good. Well, thank you very much. Informative, and it feeds right into the ideas that we need to foster debate and encourage our public policy initiatives at the Commonwealth North. A copy of their book is available for sale in back, and they are going to be around for a while to answer questions and sign, make your checks and so on out to the Cato Institute. So thank you once again for your insightful presentation. Commonwealth North produced the commemorative map in back, and please take a look and let our volunteers know if you would like to purchase one for a keepsake on your way out. We appreciate your participation on that one. Thank you all for joining us today, and I encourage you to become a member if you are not already. Please pick up a membership packet at the registration desk or contact our staff, and thank you. Have a great day.